I'm considered one of the new guys here at Grand Itasca. I got here, be 3 years ago this summer. Both Dr. Beyer and I got here about the same time. Okay, so I was raised in the Twin Cities, the suburbs, and did my undergrad at the University of Minnesota, did medical school there, then went down to the University of Tennessee, did my residency at the University of Tennessee. Following residency, I went out to the South Pacific with the U.S. Navy and did OBGYN out in the South Pacific. Wonderful experience. I got to see my first and only case of lockjaw. Do you all know what lockjaw is?
Yeah.
Yeah? No?
Yes.
Yeah. Okay, so out there they don't routinely immunize everybody. You know, they don't vaccinate. So, you know, this patient actually had appendicitis 6 weeks before and then developed lockjaw. So I'm seeing her in the emergency room and I'm trying to figure out, why is she talking like this? And I asked the ER doc and he said, well, you know, it's because she has lockjaw. And when she had her appendicitis, she actually seated herself and got the lockjaw. And I said, well, okay, so what do you do for it? He said, just antibiotics. It'll get better. It'll improve. I also got to see, go ahead.
It's curable.
Yeah. And then I got to see pregnant patients with leprosy out there. And I thought, okay, I didn't even know this existed. Okay. And it's also known as Hansen's disease. So that's another actually infection. It occurs when patients are infected with a mycobacterium. It's in the same family as tuberculosis. So this bacteria grows in the skin, and what happens is it destroys the nerve endings. So that's why these patients actually, you know, they injure themselves and then they end up with all the scarring, and that's where all the scarring and leprosy comes from. So I'm looking at these patients and going, what's different about them? Well, they had no eyebrows, and that was part of the skin disease. And again, antibiotics long term. I said, how do you track it? How do you know you've cured it? And they said, we do skin biopsies. I said, okay, all right. After the South Pacific, I came back to Minnesota. I didn't want to, but my wife did, so I'm here for love. So I practiced down in Mankato for about 10 and a half years, and then switched over to Marshall, Minnesota. Do you all know where that is? Southwest Minnesota. Got tired of the corn and soybeans. Decided I was going to come up to the woods and live on a lake. Okay, so this is what I was kind of hoping to achieve tonight. You know, just give you the multiple causes of abnormal bleeding that occurs in women. Talk about the screening and diagnosis of pelvic cancers in women. And then talk about the evolving role and the decreased use of Pap smears. We're doing a lot less Pap smears now. We found that we were being too aggressive. Yeah, happy faces. We were being too aggressive and doing too much with the Pap smears, so we've backed off. And then I want to just talk about the evaluation and the diagnosis of abnormal bleeding and kind of show you how we work that up. So I usually, when patients come in to see me, I start out just talking about normal anatomy. You know, I take everybody back to high school and just refresh your memory about menstrual cycles. So when you are having your menstrual cycle, what's happening is the brain, the pituitary gland, is sending a signal to the ovaries telling you to ovulate from one side or the other. At the same time, both ovaries start producing increasing amounts of estrogen and progesterone. Those two hormones actually make the lining inside the uterus get thicker, anticipating a pregnancy. At the end of a cycle, if you're not pregnant, that hormone level drops off and you shed that lining. Okay? That's the short version. When we talk about abnormal bleeding, we group it into different categories. Okay? The first thing we do is we rule out pregnancy. Because for the younger population, that's the first thing we want to do is make sure they're not pregnant. Then we have a whole bunch of other things to check out. So anything that disrupts that hormonal imbalance is going to cause abnormal bleeding. Pregnancy has its own issues that cause bleeding. Fun fact to know, about 1 in 4 pregnancies has bleeding in the first part of the pregnancy. Some of those go on to miscarriages, not all of them. Medications that you take can actually cause abnormal bleeding. You can have a bleeding disorder. Your platelets might not be working right, or hemophilia. Infections can cause abnormal bleeding. You can have a thyroid disorder. It could be some abnormal growth within the uterus or the lining of the uterus, or it could be cancer. So now I'm going to break these down one by one. Okay, so hormonal imbalances. If you don't ovulate on a regular basis, bleeding is going to get wacky, okay? There are certain disease entities that actually cause abnormal bleeding. Polycystic ovarian syndrome can strike as many as 5% of the female population. It's where you're just not ovulating like you should, therefore the hormone levels are messed up, and so your bleeding is unpredictable. Premature ovarian failure, that's going into menopause early. You know, the average age for menopause in the United States is 50 to 51. We have women that as early as in their 30s can actually go into premature ovarian failure. Cancer patients with their chemo puts them into ovarian failure. Our hormonal birth control disturbances, all of the different types of hormones that we use for pregnancy can certainly, screw up the whole thing. You know, that's one of the most common side effects from birth control. And then when you do get to menopause, if we put you on hormone replacement therapy, we start messing with the lining again because we're using those same hormones. We're doing a lot less of this now than we used to do. So I just gave you a list of what we're currently using for hormonal birth control. Birth control pills you know about, okay? They've changed a lot over the last 50 years. The doses that we give today are about as low as we can possibly go. They used to be much higher dosed. There is a birth control patch that you put on once a week, and you use that for 3 weeks, then you leave it off for a week, have a period, and then start over again. The NuvaRing is a small rubber type of ring that actually has the hormones within the ring itself. Patients actually get that wet, squeeze it, place it in the vagina, leave it there for 3 weeks. At the end of 3 weeks, just reach in with one finger, take it out, throw it away, leave it out for a week, have a period, and then put in a new ring. And this works great for some patients. Depo-Provera injections, this is just progesterone, okay, but it's a whopper dose. And we probably have more callbacks and more problems with this than any other method. And it's because of that whopper dose that we give patients, and then it wears down over 3 months. Birth control pills actually contain both estrogen and progesterone in varying amounts. The part that keeps people from getting pregnant is the progesterone. Estrogen was added to give better cycle control. But most of the problems that we have with hormonal birth control actually comes from the estrogen, not from the progesterone. Then we have the IUD. Does anybody remember the Delcon Shield? See a couple of heads nodding. Okay, the Delcon Shield was around many years ago. And it was a bizarre looking thing that had multiple strings from it. And it caused a lot of migration into the uterine wall. It caused a lot of infections. And so it was taken off the market, and there was a big class action lawsuit. And IUDs got a bad name for a long time, but now they're back and they're working very well. We have the Mirena that's good for 5 years. Then the Skyla came out several years ago, and it's smaller, and we use this for patients that have never had a pregnancy. Because when you place something in the uterus, when somebody has never been pregnant, you cause a lot of discomfort. So having something smaller actually works better. Okay, so bleeding during pregnancy. Like I said, normal pregnancy can have some bleeding, okay? But whenever we see it, we do some additional testing. Ultrasound is our mainstay. We look at the pregnancy, we look around the pregnancy in the uterus to see is there anything that's causing abnormal bleeding. Miscarriages are very common. I think I saw 2 today. Up to 50% of all pregnancies are miscarriages, and that number has remained pretty consistent. Many years ago, before our pregnancy tests were very sensitive, we thought you just had wacky bleeding. You know, and today, we can tell you that you're pregnant 10 days after that special night. 10 days. So after that, we can start tracking things. Tubal pregnancy, ectopic pregnancy, this is still a killer. We see these not very often anymore. We tend to pick them up pretty early. But when a pregnancy does not make it all the way back to the uterus and it starts to grow in the fallopian tube, it ruptures the tube and it causes hemorrhage inside the abdomen. And the abdomen can hold a lot of blood. You can dump half or more of your blood supply into your belly because there's nothing to stop it, okay? These patients almost all go to the operating room, and we're pretty good about getting them fixed. Placental abnormalities, smokers. have trouble with this. Smoking actually causes constriction of the blood vessels, so it decreases blood flow to the pregnancy. And so smokers tend to have smaller babies because they have a smaller placenta. Okay? Bleeding disorders. I've got a little more on this bleeding disorders a little bit later because there's several. Okay, medication side effects. Blood thinners. We put a lot of people on blood thinners. And if we have somebody who is still having menstrual cycles, well, that can actually cause increased bleeding. Because you're going to bleed anyway, right, with a menstrual cycle? So now if we put you on a blood thinner, you're going to have excessive bleeding. Hormone replacement therapy, if we start to replace your hormones, we're going to stimulate that lining. That's going to cause some bleeding. When this occurs, we want to evaluate it to make sure it's not anything bad. If it's from our medication, we say you're good to go. Endometriosis therapy. Endometriosis is where the lining that grows inside the uterus actually implants inside the abdomen. And it can actually grow in the abdomen. One of the symptoms from endometriosis is actually having abnormal bleeding. So it usually prompts ultrasound so we can evaluate things. Thyroid medications, if we mess with your thyroid, we mess with your pituitary gland, we're going to mess with your menstrual cycle. Surprisingly, all of these medications are in the NSAID category. NSAID stands for non-steroidal anti-inflammatory drugs. All of them can actually cause increased bleeding. So yes, medications do have side effects, okay? So hopefully he wasn't getting the estrogen. So the bleeding disorders, hemophilia, rarely do we see it in women. It's more in males than females. But if it's in the family, we can find bleeding there. Von Willebrand's disease, another bleeding disorder. Platelet function defects and autoimmune disorders like immune thrombocytopenic purpura. Do you know why we use big Latin names like that? No. We dazzle you with our vocabulary, then we can charge whatever we want. Okay? So ITP is, we see it in pregnancy quite a bit, where the platelets just start dropping. And we just observe that unless they get really low. If your platelets get super low, you'll just start bleeding spontaneously from the eyes, the nose, the ears. It's rare. It's very rare. Infections, rarely do we see this, but having said that, I'll tell you my partner picked one up today. Endometritis is inflammation of the lining of the uterus. Pelvic inflammatory disease is more outside of the uterus, more around the ovaries and the tubes. We don't see this very much in Grand Rapids. You know, down in the Twin Cities, they see it a lot more. Thyroid problems, you can have overactive thyroid, you can have underactive thyroid. Either of those two can cause bleeding disorders. So structural abnormalities, there are multiple. Much of the surgery that we do are because of these abnormalities. And let me just kind of show you what they look like. The uterus is a muscle. It's a very unique muscle in the human body. This muscle can actually expand out with a pregnancy and become very large, contract, and then shrink right back down again, okay? Because of that capability, we think that the uterine wall can actually grow these independent nests of muscle cells. They're called fibroids. The Latin name is leiomyomata. We don't use the Latin very much. People understand fibroids. They don't really understand the Latin. If the fibroid is actually pushing on the lining of the uterus, that's when we usually see the bleeding. But if you have multiple fibroids, it will cause pain. It causes pressure symptoms on the bladder, on the rectum. The biggest one I think I've seen has been the size of a term pregnancy. She got a hysterectomy. You can have polyps, which are growths of the uterine lining. These are fairly common. We tend to see them in older patients. Endometrial hyperplasia, where the lining inside the uterus actually grows excessively. If it grows excessively and starts becoming increasingly more abnormal, then we know you're headed towards cancer. Okay? Adenomyosis is where the lining grows excessively, but now it grows into the muscle wall instead of out into the cavity. So now the uterus gets bigger. It becomes very tender. These patients complain of pain with sex and abnormal bleeding. So, cancers. I kind of put them in order for you. so you would know what's common, what's uncommon. But I grouped them starting from the outside, working to the inside. So let's just take them one by one. Vulvar cancer, skin outside the vagina. Here's what the current rate is, 2.5 cases per 100,000 women. It's pretty rare. We usually see it after menopause. And if we have a patient that comes in with external itching and we can see a lesion, then we do a skin biopsy. And we send that to the pathologist. They look at it underneath the microscope. They give us the diagnosis. Then we move on to treatment. When we talk about these cancers, it can come from the cells on the surface of the skin. It can come from the base layer of cells, or it can come from the melanocytes. The melanocytes are the ones that give you skin pigment. So vaginal cancer, working our way in now, pretty rare. I mean, I doubt there's more than 20 cases a year in the state of Minnesota. Usually after menopause is when we see it, but it can occur very early. Does anybody remember DES? DES was diethylstilbestrol. It was a medication given back in the 50s and early 60s. And this medication was given to women to prevent miscarriages. So what we found out is miscarriages usually occur because the sperm and the egg didn't connect correctly and the chromosomes are wrong. So you have a miscarriage. So we interfered with that and tried to give a medication to prevent it. We didn't. It didn't work, but it did cause birth defects. So those are the young women that actually would get cancer as early as 20. We're usually DES survivors. Usually what we're going to hear is bleeding, and it's usually bleeding after sex or with tampons. Most of the time, they're not going to have symptoms until it's fairly far along in the disease process. Okay, so when we hear about bleeding, you know, we start from the outside, we work our way in to try and determine where exactly is the bleeding coming from. So vaginal cancer, again, can be from the surface cells, so it's squamous cell. Adenocarcinoma is usually going to come from more those DES type patients. They actually have this excessive abnormal lining out on the vagina. Sarcoma is more in the muscle cells, and these are the ones that I never see. They're diagnosed long before they ever get old enough to see me, because most of my patients are going to be like 16 years old or older. And then melanoma in the vagina is extremely rare. Extremely rare. Okay, cervical cancer. This is the one most people know probably more about. The misperception is that this is the most common. It ain't. Okay? Pap smears, when they came about, were very good at detecting early changes so that we could prevent cervical cancer. And after Pap smears came out, the cervical cancer rates in the US dropped consistently. And we're probably about as low as we're going to get now. The people that actually get cervical cancer, they're the ones that don't come to see us. They don't come to see us until they're actually having this abnormal bleeding, and by that point it's fairly far along. Again, you see the rates going up now, 9.9 cases per 100,000. 48 years old is about the average age. This is the big player, the human papillomavirus, okay? We think that this cancer is caused by that virus. And I would say that with that rate, you could be pretty certain that's what it is. So cervical cancer, early in the disease, there really aren't any symptoms. It's the Pap smear that's probably going to pick it up. But this is a very slow-growing virus, okay? From the time of exposure to the time of cancer is going to be about 10 years. And this will make more sense when we talk about Pap smears. When it's progressed far enough, we may see a vaginal discharge, which prompts us to actually do an exam. Irregular or heavy bleeding from the cervix, and we can see that when we actually do the pelvic exam. Or they may complain of bleeding after tampons or sex, okay? So Pap smears with HPV testing, still a mainstay. If somebody has had a positive Pap smear in the past, has had a hysterectomy, we'll continue to do Pap smears, but we're actually testing the vaginal skin and not the cervix. If we find a positive, we're going to go on to colposcopy. Colposcopy is Latin for cervix, and scopy is just to look at it with a microscope. This is what that looks like. We do these week in and week out, okay? Each patient that comes in to see us, they think they're the only one, and we got to tell them, no, we're doing this almost every day. Our job is to pick this up and to take care of it before it ever gets to cervical cancer, and we're pretty successful. If we're tracking a patient, I'm going to go out on a limb here and actually tell you this, if we're tracking a patient with an abnormal Pap smear and she gets to cancer, that's on us. That should never have happened. We would rather do a hysterectomy before anybody gets to that point. So again, cervical cancer, squamous cell carcinoma is the primary. Adenocarcinoma is coming more from inside the cervix. And then others are, again, like melanoma, very, very rare. So we're doing pretty good with vaccinations now. We can vaccinate for the high-risk HPV subtypes. The last I saw, we started out just vaccinating young women. But, you know, it's the guys that are transmitting this too. So it wasn't as successful in boys or men, but the vaccines have progressed. So now we're doing both boys and girls. I think that we are decreasing the rate of abnormal Pap smears and cervical cancer by up to 70% with vaccinations. Another way to prevent cervical cancer, well, if you don't have sex, you're not going to get that HPV virus and you're not going to get cervical cancer, okay? So appropriate screening with Pap smears, and we'll talk a little bit more about that. Smokers or my patients that are using methamphetamine or other drugs are a setup for abnormal Pap smears because they're usually having sex with multiple partners, so their exposure to HPV is higher. So anytime we get an abnormal Pap smear, we always try to get them to stop the drugs and stop smoking. Help yourself. Smoking does not help anybody. Nobody. I wanted to get this slide in there, and I just wanted you to appreciate how many people are giving us advice on Pap smears. Okay? There's at least 5 or 6 different organizations in here that are trying to give us recommendations. Okay? You'll see that most of them look pretty close to the same. If you pay attention to the ACOG, that's my college, American College of OBGYN. That's the one that we use. That's the one that Grand Itasca uses. Co-testing is where we actually test not just with a Pap smear, but we actually do a DNA test for the virus. The DNA test is so sensitive that we can get a positive back long before we ever get an abnormal Pap smear. Okay? So if we do that testing, you know, that helps us to kind of weed out who needs it and who doesn't. What I want you to pay attention to is when can you stop doing Pap smears? Totally. 65 years old, you're done. No more Paps. You don't need them. If you have a hysterectomy and you have not had an abnormal Pap in the past, you don't need any more Pap smears. More happiness. Also, you'll see that instead of annual Pap smears, we're now doing them every 3 years. Okay? Remember, this virus grows very slowly. It takes 10 years to get to cancer. So for that reason, we stopped doing them every year. No need. Uterine cancer. Okay, this is the most common pelvic cancer. Okay? We deal with this one fairly frequently. As it says, occurs in the uterus. It usually occurs in the uterine lining, where we see the hyperplasia that becomes progressively more abnormal. 60,000 cases a year. It's more than ovarian and cervical together. But which ones do you hear about? Cervical and ovarian. The incidence increases with age and also with weight, and also unopposed estrogen therapy, which was done in the past, we found actually causes uterine cancer. So if you have a uterus, if we give you estrogen, we're going to give you a progesterone too, because it balances it out. Okay? And that prevents uterine cancer. But we try never to give unopposed estrogen unless it's just topical and the amount you're getting is very small. The weight part of this, we know that with increasing weight, what happens is the increased fat tissue actually produces an estrogen-like substance that stimulates the lining of the uterus. So our heavier patients were very quick to do a biopsy. Most of the time, in fact, almost all of these are found when a patient comes in because they say, I went through menopause 5 years ago and now I'm bleeding again. Well, that prompts an automatic endometrial biopsy. and I'll show you what that looks like. The amount of bleeding is not a correlate with the risk of cancer. You don't have to have a lot of bleeding. It can be just spotting. Okay? It can be heavy or it can be just spotting. So you can't go by the amount of bleeding. Age, weight, and unbalanced hormones. When we make this diagnosis, we use all the tools we have: ultrasound, hysteroscopy, endometrial biopsy, and I'll show you what those look like. So ovarian cancer, this is the toughest one for us. Definitely the toughest. Ovarian cancer occurs inside the pelvis where we can't see it. It usually doesn't cause a lot of bleeding. A lot of the ovarian cancer patients actually complain more of bowel symptoms. You know, doc, I just, I eat just, part of a sandwich and I'm full. Or I have this constant nausea or constipation, and that prompts us to actually start looking closer. The screening's extremely difficult, and I'll show you why. This is the most common cause of cancer deaths. The other ones, we can usually get to it earlier, and we can cure a lot of those. So this is the one that surprised me as I was kind of making up this slide. 1 in 70 women will develop ovarian cancer in a lifetime. If we do a hysterectomy and take out the ovaries, do you still have ovarian cancer risk? If we take your ovaries out, and they've been there for 30 years, you still have a risk of ovarian cancer, but your risk is going way down, but you still are at risk. Also, what we're learning about ovarian cancer is not all of the ovarian cancer comes from the ovary. We think it's coming from the fallopian tube. Okay? We never knew that before. It was suspected, but we're now reaching the point, and I think we'll probably see a recommendation in the next 2 or 3 years. When we do tubal ligations, the college may recommend that we start just taking out the tubes to decrease the cancer risk. Okay, so risk factors: advancing age. If you have a family history of somebody with ovarian cancer and it's a first-degree relative, do you know what a first-degree relative is? Mother, sister, daughter is first degree. Grandmother would be second degree. Okay? Grandchild would be a second degree, so further out. So it's more first-degree relatives. If you have a personal history of breast cancer before the age of 40, you're also at increased risk of ovarian cancer. So those patients we have to watch closer. Have you heard of the BRCA gene? We think that, yeah, this gene we think is associated with breast cancer and also with ovarian cancer. Here's the problem with BRCA1 and 2. Most insurance companies will not even pay for that test. It's about a $2,000 test. They won't pay for that test unless you have a first-degree relative or you had breast cancer before the age of 40. That's the only time they're actually going to pay for that testing. Lynch syndrome is more of a colon issue, but it's also associated with ovarian cancer risks. For those at risk, if we pick up on some of these risks, we may offer to take out the tubes in the ovaries. Now, for people that are positive for BRCA1 and 2, they usually come in and see us and they want those tubes and ovaries taken out because they want to live. And yes, insurance companies do cover that. We don't get any argument from them. So in the screening, the lay press, a lot of the women's magazines and such were pushing that we do the CA125 tumor marker. Here's the problem. You can have an elevated CA125 level and still be normal, okay? It's estimated that if we did CA125 testing by itself, and if we did surgery to look for cancer, we would do 30 surgeries to find one cancer. So it's not a very specific test. So now the next step was to take a look with ultrasound. If we see an ovary that has an abnormal growth on it, could that signify ovarian cancer? If the patient is past the age of menopause, we will do a CA125 level because the likelihood that they'd have an abnormal level at that point in their life is low. So if we put that together with ultrasound, it shows better specificity. And so there are studies ongoing for both just ultrasound and CA125 plus ultrasound. Stay tuned. We're going to learn more about this. Currently, the recommendation is annual exams. You know, that we do pelvic exams. Yes, you may not be doing a Pap smear, but we're checking to see is there any growth in the pelvis that we need to be concerned about. So, sorry, you're off the hook for the Pap, but we still got to see you. So when we do evaluation of bleeding, okay, we start from the outside, we work our way in. And we start looking for anything that looks abnormal. If we see something that looks abnormal, we might do a Pap smear. If that's abnormal, we'll go on to colposcopy. If we see something abnormal on the outside of the vagina, we're going to do a skin biopsy. We might do lab tests. Many times I'll even check a blood count just to make sure you're not anemic from the heavy bleeding. And we'll test the thyroid to make sure that you don't have thyroid disease. We'll do an endometrial biopsy where we sample the lining inside the uterus. We might do coag studies. Here's where we go back to the history and physical, and we want to know about your family, okay? What were your periods like when you were in your 20s? Were they heavy then, or did this develop more recently? I mean, if you have a long history of heavy bleeding, we start looking at bleeding disorders. Pelvic ultrasound, if we do just a pelvic exam, that's about 40% sensitive. That means 60% of the time we're going to miss something. So we almost always do ultrasound unless we're absolutely certain that there's nothing going on. Hysteroscopy, again, scopy is where we look, right? Hyster would be the uterus. Here's where we look inside the uterus, and we can do that in the office or we can do that in the operating room. When we do an endometrial biopsy, we generally do this in the office. We have a very small catheter. This is probably about the diameter of an ink refill inside of a ballpoint pen, okay, and we pass that through the cervix, and we get a sample inside the uterus, and that gives us a lot of information. This is one of the newer additions to our clinic. We just started using this. Again, the tip on this is the same size as that little catheter that we use to sample inside the uterus, but now it's hooked up to some of the new LCD technology, right? So now I have a little TV screen about this big. This actually records, and I can download it to a computer, right? So afterwards, I can actually show you pictures of what we were seeing inside the uterus. This is where we can see fibroids, we can see polyps, we can see abnormal stuff going on. Treatment options. I always lay things out for patients this way. There's 4 general categories that we use whenever we talk. You pick your disease process. It's always the same 4 categories. Expectant management. This is medicine saying we're going to sit back and watch. Maybe it'll get better, okay? I always offer people that option and say, you know what, you can decide just to wait and see what happens, you know, but most of the time, if you've come in to see us, people aren't happy with that option. Some are. Medical management, here's where we try medicines, okay? For abnormal bleeding, if we think you have unbalanced hormones, we're going to try and balance those, and we'll use a lot of different techniques to do that. Conservative surgery, you know, 40 years ago, you'd have a D&C. Do you all know what a D&C is? Dilate the cervix. Curettage means to scrape inside the uterus. D&C used to be the mainstay. It is not anymore. We almost never do just a D&C unless it's for a miscarriage. Otherwise, we do hysteroscopy with the D&C because we want to look inside the uterus. And today we actually have what's called endometrial ablation, where we can go in and cauterize the inside lining of the uterus and destroy the lining, and the bleeding goes way down. When we started doing endometrial ablations, the hysterectomy rate, I think across the country, actually dropped in half. We do a lot less hysterectomies than we did 30 years ago. More recently, we're starting to do more hysterectomies again because we have our minimally invasive techniques, and if we tell you, if I do an ablation, 90% are going to get better, but there's 10% that may not. We can't predict who that's going to be. And some people say, I want the 100% option. And say, you know what, I want you to just take it out. Our last choice is hysterectomy. And I'm going to show you the different ways that we do that. So hormones, yes, correct the imbalance or suppress the ovaries or the endometrium. Surprisingly, do you remember where I said this causes bleeding? Yeah, we also use it to stop bleeding. Kind of weird, huh? But we know it works. So we always try that with everybody. Almost everybody can tolerate these medications. Hysteroscopy to look in the uterus, remove any abnormal tissue. DNC we talked about, ablation we talked about. When we do hysteroscopy in the operating room, of course we're using a lot more instruments. And when we do this in the operating room, we're not looking at the patient. We're watching everything on a TV screen, okay? And so everything I'm doing is up on the TV screen and your hands are moving, but you're not watching your hands. Procedures we can do with that hysteroscope, well, first of all, we can make a diagnosis. We can remove polyps. We can remove small fibroids. We can remove a foreign body. Sometimes people have an IUD and we can't find strings externally, so we actually go in and take the IUD out. It's rare that we have to do that. We can usually get it out in the office. A septum is a growth inside of the uterus. Okay, these patients we will see because they have recurrent miscarriages. So we do a dye study and find out that there's an abnormal shape inside the uterus that's causing them to have recurrent miscarriages. So we can go in and actually remove that tissue and normalize the cavity. I've got a patient right now that we did that on a year and a half ago, and she's now 6 months pregnant and doing great. Ablation, destroy the lining. Hysterectomy, we can do one. The old-fashioned way was to make a big incision and then go in and take the uterus, tubes, ovaries, cervix. If we do an abdominal hysterectomy, we consider ourselves failed. We tried not to do those, and I think in the almost 3 years I've been here, I think I've done 3. But if somebody has a uterus with big fibroids, I'm not going to get that out through little tiny incisions. I don't have the instruments to do it. Vaginal hysterectomy has been around for a long time. Here's where we operate through the vagina and take out the uterus, the cervix, tubes and ovaries if we need to. Laparoscopic, small incisions, but again, everything comes out vaginally. Or we may use a combination of techniques. When we show this to patients in the office, here's the big incision. The vaginal hysterectomy, everything's coming out vaginally. The total laparoscopic hysterectomy, we make 3 small incisions, one at the belly button and one on each side. And then our instruments will actually detach everything, and then we can actually bring everything out through the vagina. Okay, so that kind of sums all that up. I just want to tell you, okay, what's coming up ahead for folks here in Grand Rapids, okay? So we have a 3rd OBGYN coming to join us in August. Her name is Katie Johnson. She's coming directly out of residency at the University of Minnesota. She's a wonderful young lady. We're really looking forward to having her because I'm going to do less call. But she'll be working with us as we keep developing things. There is a new women's clinic being built along with the Cancer Center. We are adding some new equipment to the clinic, so when patients come in, we can actually do that hysteroscopy right there in the office. Instead of taking you to the operating room, we're going to add an ultrasound, so we can do an ultrasound right there on the spot. And we're going to update much of the other equipment. But what's most important is that this will be a discrete area. Do you all know where the gift shop is at the hospital? Okay, we're going to be right behind the gift shop. And this is going to be a discrete area for our female patients. One of the issues that we had with the current clinic setup was that with those long hallways, if you're sitting in that room and we have you get undressed and then we open up that door, you don't know who's walking by, right? And these hallways are all mixed with male, female. So now this will be a discrete area for women where we can, give you more confidentiality. And also for our young patients that get pregnant, well, maybe they don't want everybody to know just yet. So, we can put them in that area and kind of protect their privacy. Well, thanks for your attention.